Hi, everyone. David Putrino here, professor in the Department of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai. I recently did an AMA for the SameU Foundation, and there are a lot of questions we didn't get to because lots of people had a lot of questions. So I'm just going to go ahead and in rapid fire answer the questions that we didn't get a chance to get to during the live event. So the first one here is we often hear doctors say we still don't know a lot about how the brain works. What are you excited about on the neuro repair research front? This is a really great question, and I agree. We often hear a lot of adages from clinical providers about the brain. You know, the brain is a mystery, and we don't know how it works. And after a brain injury, we often hear people say, you know, plan for the worst, but hope for the best. But really what I'm excited about is when we're talking about recovery of movement, recovery of motor function, things like walking, using your arms and legs, using your hands for fine motor tasks, we're starting to see a lot of really exciting progress in the world of implanted neurostimulation. This is a whole field of clinical research where we're implanting devices into the central nervous system that actually stimulate nerves at certain points in the rehabilitation process. And we're starting to see incredible results. We're starting to see people who couldn't walk before being able to walk again. We're starting to see people who couldn't use their arm regaining function of their arm. And these technologies are right on the cusp of becoming commercially available, covered by insurance, covered by government health programs in single payer systems. So that's an area of physical rehabilitation that I'm really excited about. In terms of rehabilitation of other functions for people who are more severely disabled, we're seeing great leaps and bounds in the world of brain-computer interfaces. These are devices that record brain activity, decode intention from brain activity, and then go on to control external devices like robotic arms or simply tablets or environmental controls, so that someone who is locked in or someone who has a severe physical disability can still control their environment just by thinking about it. So they can think, I want to turn on the light, and the light will turn on. Or they can imagine the words that they want to say, and an artificial voice will speak for them. So these, again, are technologies that 20 years ago we would not have thought were close to getting into the hands of patients. And now we're in exciting clinical trials, in things that are, really coming to the forefront. And then there are a ton of restorative therapies that I'm very excited about. The world of mitochondrial transplantation, which is a form of transplant where we implant mitochondria into damaged cells, and these cells regenerate and recover, or stem cell therapies. These are all very, very exciting biological interventions that could be improving brain health for years to come. Next question, is there a go-to book for understanding strokes? Also wondering if there is a resource for social support in Los Angeles. I can't speak to social support in Los Angeles specifically, but I can say that groups like SameU are always working on creating large online environments for people to get together and connect and share their stories and engage in peer support. And I also think that other platforms out there, things like Patients Like Me and other social groups, are always really, really helpful to get involved in and engage with if you're looking for social support. As to a go-to book for understanding strokes, I think probably one of my favorite books about stroke recovery and brain recovery in general is a book by an author named Norman Doidge, and he wrote a book called The Brain That Changes Itself. I think that that's a really wonderful book for understanding how the brain recovers from brain injury.
There also, I don't know if this needs to be in the recording, but I'm quite certain that there is social support in Los Angeles.
Oh, I'm sure there is. I don't know. I just don't know off the top of my head. What?
No, but I mean, I think I know people who have either volunteered in stroke social support or who have experienced it. So I will try and find, so you can send the same people, but I don't personally know.
Fantastic. That'd be good.
Okay.
How does brain injury recovery differ between children and adults? This is a great topic for conversation. In general, when we're thinking about the brains of children, the younger the brain, the more plastic it is, the more able it is to recover from sometimes quite catastrophic damage, and completely rewire and function sometimes in an almost very normal fashion. Because kids are constantly learning and their brains are constantly learning, they're actually capable of some very extraordinary things. And as a result, when kids experience a brain injury in early life, their chances of going through a process called neuroplasticity, where the brain sort of remodels and rewires itself to adjust or accommodate to the injury, is much, much higher than the sort of potential for recovery that adults experience. It's not that adults do not experience sometimes extraordinary levels of recovery. It's just that the older you get, the less of a potential for recovery that your brain experiences. And so if you're a very old person, so if someone is in their sort of 9th decade of life, or they're in their hundreds, that brain, statistically speaking, so not always, but statistically speaking, is going to have less of a capacity for neuroplasticity and remodeling and rewiring than someone in their first year of life. That individual will have a lot of potential for recovery. So really the main difference in the way that brain injury recovery looks in children and adults is that potential for remodeling and recovery. But again, these are all averages. So that's not to say that we don't work just as hard with older adults as we do with our young patients, because everybody across the board responds to high intensity, frequent rehabilitation. It's just the size of the effect that may differ. How do you help a child understand what has happened to them after a brain injury? So this is a really tough and sensitive topic. And I think it really it is something that needs to be addressed. This is something that needs to be addressed with a lot of sensitivity, but often the way that we tend to talk about this is by explaining that everybody is a little different and everybody interprets the world a little bit differently. Everybody moves a little bit differently, and everybody's nervous system can respond differently to different things. And so really helping kids who may have experienced a brain injury understand that there is a spectrum of how our brain responds to things and manages different things, and helping them find where they lie in that spectrum, and focusing on how to change an environment to suit their needs, as opposed to thinking of some of the changes that they've experienced after their brain injury as deficits per se, can be really, really helpful to helping kids understand what's happened to them and what their brain is feeling like, after an injury. I think probably for reference, one of the best examples of this that I have seen has been the work of Sesame Workshop, when they introduced Julia into Sesame Street, which was, a young lady on the autism spectrum, and looking at the way that they created an environment for Julia to sort of exist in Sesame Street as a new character, and all of the resources that they also released afterwards. I think that although that's not a brain injury that we're talking about there, it's a really good example of how to approach a topic of someone who is no longer neurotypical or is currently not neurotypical, and how to address the situation. I think it's a really great example of how to manage. What advice would you give for relatives or close friends, assuming there is any time or preparation at all, regarding the mental strain on these groups? Part 2 to follow.
Those groups being relatives and friends.
Oh, okay. Let me redo that. What advice would you give for relatives or close friends, assuming there is any time or preparation at all, regarding the mental strain on these groups? So I think that something that's not spoken about enough is caregiver burden, and also just in general the sort of stress or the strain that brain injury can can inflict upon everybody in the community of the person who has been hurt after a brain injury. And in terms of, what advice I would give, I would say, the best thing that we can all do in a situation as unpredictable as brain injury is take things one day at a time, is to do your best at all times to create an environment of calm and an environment of peace and an environment of optimism around the person who has been hurt. If you feel like there are days that you can't do that, that's fine, but remove yourself from the situation and find ways to make sure that the person that you're caring for or the person that you're related to is still supported as you remove yourself from the situation. And really making sure that as a caregiver or a family member of someone with a brain injury, that you are also getting the support that you need. You are also speaking to a psychologist if that's something that you need. You're also getting mental health support. You're also engaging in social support and finding other people in your situation who can, help you out and mentor you through some of the tough situations you may face. To what extent can this emotional strain affect or potentially slow the physical and mental health recovery of patients? As I was mentioning earlier, I think that it can have a profound effect on a loved one who has gone through a brain injury, because what we want to do is try to create the optimized environment for healing after someone has gone through a brain injury. And people with a brain injury can experience a lot of issues with filtering out sort of stimuli that are coming in, and also with regulating emotions that they're either perceiving or that they're experiencing. And what I mean by that is, if someone with a brain injury is in a situation that is maybe loud or stressful, unlike someone who doesn't have a brain injury, they may have a very difficult time to ignore the loud environment or ignore the stressful situation, which can lead to physiological distress, which is bad for recovery. Similarly, if someone is around them who is very, very stressed out, or is spreading a lot of negativity, or is just in generally a terrible mood and is losing their temper quite quickly, that's something that is hard for a person with a brain injury to filter out or ignore as well. And again, that can lead to heightened stress and difficulty with regulating that stress. So once again, it really does put their recovery in jeopardy. The reason it's so important for people who are in the immediate sort of life of someone who's just sustained a brain injury to remain calm, to remain positive, to remain supportive, and to, without judgment, when it is a bad day for them, because there are going to be bad days, to remove themselves out and re-regulate before re-engaging. That can have a very profound and positive effect on long-term recovery of a person with a brain injury. Okay, how can family members, friends, or caregivers best support someone going through neurological recovery? I think that,
I feel like we answered this one. I feel like we can skip this one.
I think we can skip this one too.
Okay.
Do you have any comments on nutrition to help prevent future strokes? Mine was a right brain ischemic stroke on the basal ganglia. I have left hand incapacity and left leg weakness 2 years later. Well, I'm sorry to hear about your stroke. I think the best evidence that we have on nutrition to help prevent future strokes is all around maintaining healthy blood pressure. Almost 50% of recurrent strokes after a first stroke are related to uncontrolled blood pressure. And so in addition to monitoring your blood pressure and taking your blood pressure medication and cholesterol medication, if that's also been prescribed to you, the next thing to do is look at diet. There have been multiple publications on something called the DASH diet, which is a really good way of limiting sodium in your diet to maintain healthy blood pressure after you have sustained a stroke. And that can be very, very helpful to avoiding a second stroke from occurring. And then similarly, avoiding foods that are high in cholesterol, specifically LDL cholesterol, which is the form of cholesterol that leads to plaques in your blood vessels, and therefore the possibility of another stroke forming, especially in the case of an ischemic stroke, which is a small clot that blocks a vessel. When you have buildup in your blood vessels from high cholesterol, that can lead to clots being thrown and recurrent strokes. So following dietary guidelines to avoid high LDL cholesterol and high blood pressure, maintaining your medications very, very closely and making sure that you know your numbers. So know what your blood pressure is, know what your LDL cholesterol is, and continue to work with your doctor to intervene as necessary. Those are the most important things that you can do to avoid and prevent a future stroke. What emotional challenges are often overlooked during rehabilitation? I think a general statement that I will make is that we do not have enough skilled neuropsychology attending to people with brain injury in general. So I think that, just like we, in a good rehab facility, after a stroke or a brain injury, we will spend, 3 to 4 hours per day for the first 3 months working on physical conditioning, getting upper extremity function back, practicing walking, et cetera, et cetera. We barely spend any time at all. I think maybe, in most good facilities, maybe neuropsychology comes by and sees a stroke patient, if you're lucky, once a week. So I think that we don't get enough neuropsychology in general to help people deal with the emotional changes and the negative emotions that can come along from being newly disabled by a brain injury. But in addition to that, I also think one of the things that is frequently overlooked is what we call social health. And this is the extent to which you're able to maintain or form new relationships, which can lead to loneliness and social isolation. We rarely see loneliness and social isolation being addressed after brain injury, even though people who are newly disabled are 4 times more likely to go on to develop loneliness and social isolation. So I would say that those emotional challenges, both for caregivers as well as newly injured people, are probably the most prominent social health issues. How can I protect or prepare the brain if a future injury or surgery is statistically likely? This is a really good question, and we could talk all day about some of the experimental protocols that are available for brain protection or brain preparation. But if we were to boil it down to 3 things that have been proven over and over and over again to be the most neuroprotective for brain health, I would say that those 3 things are moderate intensity physical activity most days of the week. And what that means is at least 30 minutes of exercising at a level that allows you to maintain a comfortable conversation while you're exercising, which is sometimes called zone 2, aerobic exercise, but making sure that you are engaging in moderate activity exercise most days of the week. So 5 to 7 days of the week. So exercise, social connection. So making sure that you are that you have a rich social life, making sure that you've got friends that you can talk to, making sure that you are engaging with people on a regular basis. This is, again, statistically proven to slow cognitive decline and be neuroprotective for damage for after brain injury, making sure that the effects of brain injury are not as dramatic. And the final one is sleep, ensuring that your body is getting enough restorative sleep. At least 7 hours a night, up to 9 hours a night is optimal. Below 7 hours a night can mean trouble for your ability to recover from a brain injury, or is no longer having a neuroprotective effect if you're not sleeping at least 7 hours per night. Would brain injury make us more susceptible to alcohol years on, and are activities such as roller coasters or skydiving to be avoided even if you've largely recovered? I had concussion and SAH, which is subarachnoid hemorrhage, separately. So I would say that the way to think about the effects of alcohol on an aging brain or an injured brain are that we all have a certain amount of cognitive reserve. So we have this concept in neuroscience and in brain health of cognitive reserve, which is, let's just say you've got a full tank of gas or a full tank of petrol, depending on where you're listening to this. And that's your cognitive reserve. That's how much, fuel you have in reserve for your brain. And there are certain things that will lower that reserve. So getting infected over and over again with viruses can lower that reserve. Being knocked in the head multiple times by a concussion can lower that reserve. You can also increase your reserve by speaking lots of languages, by reading lots of books, by memorizing lots of things over and over again. When we look at cab drivers in the UK, they have larger areas of their brain, the hippocampus, than regular people because they have to memorize a lot of different locations. These are things that increase cognitive reserve. And so if you think about a brain injury, a concussion, or a subarachnoid hemorrhage, that has caused the lowering of your cognitive reserve. Unfortunately, Now, your reserve may be massive compared to other people, but unfortunately, you've experienced a shrinking of your cognitive reserve. So alcohol use beyond minimal alcohol use, so like if you're binge drinking, or if you're engaging in moderate alcohol use, which is according to the Department of Health is considered more than 20 standard drinks per week, this is something that demonstrably shrinks your cognitive reserve over time. So logically speaking, the combination of alcohol use and brain injury has the potential to shrink your cognitive reserve. So it is something that is best avoided if you're trying to maximize your cognitive performance and maximize your ability to maintain good cognitive health long term. In terms of roller coasters and skydiving, there aren't actually any studies out there to tell you to necessarily avoid these activities. This is more of a conversation directly with your doctor who understands your clinical situation, because yes, sometimes being in a situation where you may be experiencing altered levels of air pressure, or in a situation where like on a roller coaster or skydiving, you may be shouting or screaming during this stressful situation. There may be some folks where that is absolutely contraindicated. If you continue to have certain vascular structures that are risky, or if your subarachnoid hemorrhage has not fully healed, these are things that absolutely should be avoided. However, on the other side of the coin, there are some people who had a brain injury, fully recovered, and now they can absolutely engage in these activities. So that is more of a specific question for your clinical provider who knows your past medical history. If you have an ischemic stroke from a vertebral artery dissection, are you more susceptible to having another stroke? Great question. In general, statistically speaking, the act of having a stroke places you at higher risk of having another stroke in your life. So all of the epidemiological studies that we have tell us that once you've had one stroke, your risk of a second stroke is higher than anyone in the general population, which is why we strongly encourage folks who have had one stroke to be very, very vigilant with knowing their numbers. So monitoring their blood pressure, monitoring their cholesterol, going and seeing the doctor. If you did have a vascular issue, an arterial dissection, go and have an angiogram every single year to make sure that your blood vessels are healthy and that your provider is comfortable that another vascular event is not going to occur. And I do know that it can be tough to stay on top of these things. In many cases, the health systems can be quite, confusing and difficult to navigate, but it really is the best way that we can avoid additional vascular events is to monitor things very, very closely after your first stroke, because yes, you are statistically more likely to have another stroke. As the years passed, does a coiled aneurysm become less or more risky to have an issue so that it might need surgery again? Great question. Typically speaking, coiled aneurysms don't need to be revised. But just like in my answer to a previous question, someone who has had an aneurysm before does have an increased risk of additional aneurysms after they've had a first aneurysm. And so the best thing to do is to make sure that you are getting regular angiograms, you're working with your neurosurgeon who coiled your first aneurysm, to monitor closely over time to make sure that no new aneurysms form. And again, statistically speaking, although you are more likely than the regular person off the street to get another aneurysm, this is still a low probability event. It's just something that we want to watch for, and that's why annual angiograms, if you've had a stroke, if you've had an aneurysm in the past, are a really good idea. I had Wallenberg syndrome with my acquired brain injury. Is it possible to get the ability to feel pain and temperature back? This is a great question. We have had some success in sensory reintegration after Wallenberg syndrome in some of our patients. I will say that it can be tricky to prognose who is going to get sensation back and who is not. But I will say that we have had really good results with spinal cord stimulation, non-invasive spinal cord stimulation. So using things like transcranial magnetic stimulation, as well as transcutaneous spinal cord stimulation, as well as just general sensory reintegration. So using tools like virtual reality and using just general sensory, physical sensory reintegration tools. So exposing the extremities to cold and heat and different textures and lots of sensory experience has been effective in helping some folks with Wallenberg syndrome reintegrate their senses and experience pain and temperature again. What is the recovery rate of AVM, which stands for arterial venous malformation, in 15-year-old boys if on non-dominant lobe? What does recovery look like? Unfortunately, this is a very broad question. AVM recovery really depends upon the size, the location of the AVM, and the ability to intervene on the AVM. So I'm sorry I can't answer this question, as it seems like it's quite specific, but in many cases, people can have their AVMs removed, and there is absolutely no negative outcomes and no negative effects, and one surgery and it's done. And in other cases, if the AVM is larger, if it's in a tricky location, removing the AVM and recovering from the AVM can be quite challenging. So we really need to take AVMs on a case-by-case basis and manage them individually for the person who's living with it. Botox has helped my hand to release some, I'm assuming this word is spasticity, and also reduce pain. Will I need Botox for the rest of my life post-stroke? So Botox is a really great strategy for helping people with some of the tone that they experience, and as you mentioned, some of the pain that they experience in their hand. When we're thinking about approaches to tone, it really does depend on some of the other things that are going on in your global recovery. Are you still receiving intensive rehabilitation to, the gold standard? What would be great is if we could be rehabilitating your hand aggressively, so that when you feel this tightness in your hand, when you feel the tone coming on, your muscles on this side are strong enough to open the hand and resist the tone. And so if while you're going through the sort of Botox period where your hand is released from spasticity and not in pain, if you're also getting extensive rehabilitation to strengthen your extensors so that you can resist tone when it comes on, that is going to be super helpful for not needing more Botox in the future. Whereas if rehabilitation is not really working for you, there is a chance that you will require long-term Botox to continue to experience that release and that relief from tone. So it really depends on where you are in your recovery journey and if there are any other rehab strategies that can be employed to strengthen the muscles that can resist the muscle tone long-term. Is it weird that I still jolt up as I'm drifting off to sleep 5 years after 2 burst aneurysms, as well as having a numb arm? My movement is fine all day. Then just as I drift off to sleep, this happens. You know, this is a very specific question, and I would have to know a little bit more about who you are and what your medical history is to fully delve into an answer here. But one of the things that I would say is that none of these things are weird. You know, I would say that after a brain injury, that which can happen will. And what's more important is that you can find a provider who will work with you to get to the bottom of why is this happening? You know, why are you sitting up, you know, jolting up, bolt upright as you're drifting off to sleep? What can we be doing about your sleep routine to prevent that from happening? Is it related to the trauma of the 2 burst aneurysms, or is it related to something physiological happening hormonally? You know, that your cortisol isn't cycling the way that we want it to. Is it related to sleep disruption? And maybe we need to get you a sleep study to figure these things out. So I would say that rather than thinking of it as weird, I would say it's interfering with your life. So anytime a symptom like this is interfering with your life, let's dig into it a little bit more. Let's find a provider who will partner with you to figure this out. I want to ask about the chances of my vision returning from a bleed-induced stroke. Also struggling with projecting my voice when singing. I think my visual condition is called hemianopia. Hemianopia is a condition that occurs when parts of the optic tract are damaged. So there are different types of hemianopias that can occur, but effectively they're related to different parts of the optic nerve being damaged. Now, typically speaking, unfortunately, the optic nerve does not recover so well. And so the best thing that we can typically do for hemianopia is helping you with strategies to learn to live with the hemianopia. So helping you with strategies of how you can sort of scan a room to make sure that you're taking everything in safely, and that you're seeing everything that's in the room and not missing any details, and setting you up with special sets of glasses, such as prism glasses that can help you to take in areas of your environment without necessarily having to continually be scanning the room or scanning the environment that you're walking through. That being said, there are some really exciting therapies that are emerging for optic nerve regeneration. And I would say that although none of these therapies are ready right now, they are emerging rapidly. And there's some really exciting research that might indicate that we may be able to start treating some optic nerve injuries soon. So hang in there, and I hope that there's some good news for you soon. My son had an acquired brain injury, and his resulting cognitive impairment makes him very non-communicative. We're trying to get him to use an AAC, but he resists / doesn't understand how to use it. I'm really sorry. This can be a really tough situation to deal with. AAC is often AAC for those who don't know stands for adaptive and augmentative communication. So these are strategies, sort of non-speech strategies for allowing someone to express themselves that range from a word board, where you have words on a board and you point and the person nods or shakes, depending on whether you're pointing to the right word or letter, all the way through to eye tracking technology and buttons and switches that can help someone to communicate with others, even if speech is challenging for them. In the case of someone who is less interested in using AAC technologies, again, one of the things that we try to get to the bottom of is why might that be? In a case like this, what we would typically do at our center is work with a neuropsychologist or neuropsychiatrist to see if there are any strategies, both medication or neuromodulation, so brain stimulation, non-invasive brain stimulation, that we can use to improve focus and improve attention in the individual that's struggling to focus during AAC usage. But I will acknowledge that this can be a very, very tough situation and frustrating for everyone, frustrating for the caregivers, as well as frustrating for this young person with a brain injury who may be trying to figure out the rules of the AAC system, but can't quite grasp them because the brain injury is making it difficult for them to sort of manage more abstract concepts. So hopefully you can access some neuropsychologists or even physiatrists who can help you with this, thinking about medication on neuromodulation strategies to help with focus and attention. But I do acknowledge that you're in a tough situation, but I hope it works out. It's been 37 years since my epidural hematoma requiring a craniotomy. I can write 1,000 words in an hour. Is my brain wiring around the problem? And do I need to worry long term? I would say that one of the things that has been a theme of this session of answering questions is if you're functioning well, there's no need necessarily to worry, but so long as you're monitoring yourself long term. So long as you're monitoring your blood pressure, you're staying healthy, you're taking your medications, these are the things that prevent decline. These are the things that prevent other events from occurring. So I think that if you're doing great, right now, congratulations. That is awesome. And we love seeing a full and good recovery. And to just keep that going, making sure that you're looking after yourself, making sure that you're exercising, you're eating right, you're tracking your numbers, and you're staying healthy. I have lesions on my left temporal lobe, and I have difficulty making out speech if it's not clearly spoken. Hearing aids are not helping as much as I had hoped. Anything I should be doing? Again, this is a very specific question, but generally speaking, when we're dealing with hearing issues that maybe a speech, maybe a hearing aid isn't assisting as much as you'd like, what we really want to do is go deep on an audiology assessment and really try to understand what is causing the difficulty with understanding speech. Is it a hearing issue? Is it an issue with comprehension that is happening in the brain? Are there pathways that have been disrupted? And typically, speaking to a good audiologist, speaking to a good ear, nose, and throat specialist is the first step in trying to understand what could be going on. The feeling of wetness or goosebumps in the head or the brain. Why does this happen? There are lots of reasons why you might experience sensory changes in the head or the brain. And I always recommend if you're experiencing lots of sensory changes, that is usually a sign that you should head to the doctor and get some imaging done. Typically, if you're experiencing this sort of like tension and wetness and goosebumps in the head, and even the sensation of inside of the head, it's probably a good idea to get some imaging of the head and the brain, as well as the neck, to see if there's any reason to believe that there might be some nerves getting impinged that could be leading to this. But in general, sensory changes can happen for lots of reasons. And so getting someone to take a look at these things comprehensively with imaging is a really good idea. I used to get really bad random migraines where my eyes would go blurry. I suffered a focal seizure in 2022 and a brain hemorrhage most recently at the end of last year. Is this linked to neck muscles? Well, I'm really sorry to hear about what you went through. I would say that, again, this is something that should be really comprehensively worked up. I would say that no, focal seizures and brain hemorrhages are usually not linked to tight neck muscles. But, migraines and blurry vision can be. These are things called cervicogenic migraines, meaning migraines that come from the neck. Now, in general, if you're experiencing migraines and you're experiencing blurred vision, and then you went on to experience a brain hemorrhage, that would tell us it's less likely to do with the neck and it's more likely to do with the brain. So making sure that you're keeping your appointments with your neurologists and your neurosurgeon to continue to surveil your brain vasculature after this most recent event is the most important thing you can do to maintain good health. But I'm really sorry that this happened. How do you know whether symptoms are from the brain injury itself versus stress, anxiety, or trauma afterwards? This is a great question. And, I think that this is something a lot of brain injury survivors experience, is a lot of feelings of, a lot of feelings that could be either. They could be stress or anxiety or trauma related, or they could be symptoms of a damaged brain. And I think, again, the most important thing to do is to find a good provider who will partner with you to tease apart some of these problems and really try to understand what happens if we give a treatment that is designed to address stress and anxiety. Do your symptoms reduce? If they don't reduce, maybe we need to try something else. And maybe this time we'll try something that is geared toward treating the brain injury. And if we see improvements at that point, that gives us a direction to move in that might help some of the symptoms that you're experiencing. So it can be a little bit of a frustrating process of discovery, which is why it's most important that you find a clinician that is willing to work with you every step of the way to help tease out some of these problems. In your experience, how much can altered neurophysiology directly change someone psychologically, even without a traditional traumatic brain injury, and what actually helps people to adapt? I would say, in answer to the first question, absolutely. Altered neurophysiology can lead to psychological changes and psychological symptoms. We see this all the time with neuroinflammation. People who experience surges of inflammation in their brain, whether it be from diet or whether it be from histamine issues or whether it be from bad lymphatic drainage in their brain. We see mood changes associated with that. We see people becoming bad-tempered or experiencing anxiety or experiencing depression. And so altered neurophysiology absolutely can cause these things. And in terms of what helps people to adapt, I would say, two things: finding the neurophysiological alteration or adaptation and treating to the best of your ability. But also, if that is not necessarily possible, if it's something that you can't quite control with medication or a behavioral intervention, then working toward tracking your symptoms and working to predict your symptoms based on your symptom tracking. One of the things that can be most helpful for someone who's experiencing behavioral or physiological changes that they feel like they're not in control of at all is to be able to track them to a point where you understand when they're going to happen and why. Just knowing when something is going to happen and why can be incredibly comforting for someone who previously felt as though they had no control at all over symptom presentation. And so if it can't be treated, then it can be tracked. And hopefully when it's tracked, it can be predicted so that you can prepare for it before it occurs. I experienced the same symptoms due to long COVID with MECFS. How do I know if it is long COVID or due to brain injuries? I think this is such an important question. Some of the things that we have seen in our team's own research with long COVID is that long COVID has this ability to augment previous injuries. We often see this in our long COVID patients, where folks who have experienced a long history of concussion, when they have long COVID, their cognitive symptoms are exaggerated. They have more cognitive symptoms. People who have had lifelong gastrointestinal issues, their long COVID will manifest by worsening their gastrointestinal issues. So it's a really hard problem to tease out. Is it the brain injury or is it the long COVID? And often I think, the correct answer is it's both. But unfortunately, one is feeding on the other a little bit more in addition. So yes, you have long COVID. Yes, you have a brain injury, but also the disease process of your long COVID is making your brain injury symptoms a little bit worse. I really hope that we can work to find some solutions for you as we continue to learn more about long COVID and brain injury. What is the potential link between a TBI at childhood that affected the prefrontal cortex and dysthymia? So I think that when we deal with prefrontal cortex damage, we're really affecting somebody's ability to build out executive function. Executive function is this sort of functioning of our brain that allows us to regulate emotions. It allows us to form a plan. It allows us to execute a plan in sequence. It allows us to adapt to new situations. And often when somebody experiences damage to their prefrontal cortex, their executive function can be disrupted. And particularly when a TBI occurs that affects the prefrontal cortex in childhood, it can mean that certain skills go undeveloped or underdeveloped. And as a result, it can mean that someone really has a hard time to regulate emotions. And so dysthymia, which is this sort of like just long-term persistent depression, can often develop simply because it's really hard to manage emotions, and it's really hard to let go of negative emotions when they emerge, which of course can lead to feelings of hopelessness, feelings of helplessness, which can contribute to feelings of depression. So I would say that there is a potential link between these two things, and that the potential link really lies in our ability to regulate emotions and control emotion. You know, I know that there is a lot of continued study around prefrontal cortex injury and sort of long-term feelings of depression. So hopefully there will be some you know, helpful therapies out there soon. There are also some very skilled neuropsychologists who can teach cognitive remediation therapies and problem adaptation therapies that help folks with a brain injury to regulate some of these emotions. I have FMD and discovered after subarachnoid hemorrhage. I've been told to limit lifting to closing the boot. What would you recommend for someone like me who wants to improve? Yeah, this is FMD, which is a sort of a vascular problem. It can be very challenging to treat. And I think that when it comes to, you know, what you can do to hope to improve, if you can find, you know, a good vascular specialist who can work with you, there are some medications that can work to strengthen the endothelium, which is the sort of inside of our blood vessels, and make them more healthy. You know, there are, you know, experimental studies being done on substances, you know, natural substances and supplements such as pycnogenol, which are out there in the world that have been studied for their effect on endothelial health, as well as simply medications such as statins that we think of as drugs for high cholesterol, but they can also be used as drugs to strengthen blood vessels and improve vascular health. So I would say it would be great if you're hoping to improve with your FMD. It would be great to speak to a vascular specialist who may be well versed in some of these protocols. This is not common knowledge, so it would be good to speak to someone who's well versed in vascular health protocols that may allow you to, you know, improve your vascular strength and thereby improve the activity, increase the number of activities that you can safely perform.
Is closing the boot like a common PT activity? I've never heard of this.
Closing the trunk of a car.
Okay, sorry.
I apologize. Yes,
Americanism.
I should have translated that.
I thought this was like a mysterious term of art.
I have been diagnosed with hemiballismus on my right side due to an acquired brain injury. The condition didn't show for about 6 months while I was doing rehab. Is there anything that would make things easier? So for those of us who don't know, hemiballismus is a condition whereby people sort of have uncontrolled movements of one of their arms or one of their legs. So they will experience these sudden uncontrolled movements. You know, there are rehab approaches to hemiballismus where, you know, where we can try to calm down the nervous system or try to minimize these hemiballismus movements by providing sort of constant stimulation to the limb that is experiencing hemiballismus. Some of the non-invasive and safe treatments that we've seen have been related to vibrotactile stimulation. So, you know, wearables that can sort of just gently vibrate on the limb and provide sensory stimuli that back to the thalamus and to the sort of deep brain structures that remind the body of where the limb is in space, so that the limb doesn't suddenly jerk out and move in another direction. And similar things have been done with just simple devices. So rather than a wearable device, like simple things like wrist weights, something as simple as that can, again, just provide that sort of sensory feedback to the brain to say, hey, the limb's here. There's no need to correct the position. It's remaining here by my side. In the instance that the wearables and weights aren't working, there are medications that you can speak to your doctor about that can sort of calm down the nervous system. And some neurologists have also approached, deep brain stimulation approaches similar to what we use for Parkinson's disease, have also been attempted for hemiballismus. So there's a range of minimally invasive all the way through to, surgical options that can be trialed for hemiballismus. But obviously we would start slow with some of these vibrotactile stimulation and sensory strategies first. What is your feeling about potential in psychedelics to boost neuroplasticity? And if it were effective, what could a TBI survivor expect from that? I think that this is a really exciting area of research, and it's an area of research that we at Mount Sinai are engaging in as well, because we have a center for psychedelic medicine. We have seen some really exciting results in the field of motor recovery after a brain injury, as well as PTSD and depression treatment after a brain injury. I think what is most important about this area of research is it requires a lot of trained administration. So it's not just you take a psychedelic and you expect to magically be better. The psychedelic needs to be paired with very skilled and intensive therapy afterwards. Once you open a plasticity window, you need to make the most of it for the 3, 4, 5 weeks after that opening of a window. One of my favorite psychedelic researchers is often heard saying, don't trigger neuroplasticity unless you have a plan. And so I think that there's a lot of premise, but you need to have a plan for what you're going to do with all that neuroplasticity once you trigger it. What do you think about higher doses of omega-3 fish oils and recovery from TBI, particularly around the anxiety depression equation? I think that omega oils are very important for brain recovery, but something that needs to be paid attention to, and this is where you should work with a nutritionist or a registered dietitian, is it's not just about omega-3 intake, but it is about the correct balance between omega-3 and omega-6 that is optimized for brain recovery. So I do think that there is really good evidence to suggest that supplementing appropriate levels of omega-3 and omega-6 in the right ratio can promote and encourage brain recovery, but making sure that you're working with someone who is knowledgeable in that correct ratio is crucial.